Well, hi, everyone. My name's Jen James. I am a sociologist and a bioethicist. I work at the University of California, San Francisco. I've been involved with the wisdom study for a few years, looking at social and ethical implications of the study. And generally, I'm involved in research on experiences related to breast cancer, screening for cancer, understanding cancer. And I'm excited to be here with all of you today. So as we said on the slide, if you want to introduce yourselves in the chat, that's great. We love knowing who's here, why you're here. And yeah, do you want to go to the next slide? Whoever's controlling the slides, I realize I don't know, it's Allison. So our goal with these sessions, this is I think our third now monthly session that we're having, is to have conversations about what's going on in breast health and health more broadly, addressing questions, bringing in folks who do research and clinical care on different topics together to talk about what we need to know, what everyone needs to know about their health, what we should be doing, help understand for us to work on the research side, what we should be looking into in more depth. And our sort of mission or our goal is to make sure that we're finding ways to move together towards equity and better outcomes in breast cancer for everyone, which obviously has not been the case in the past. We know that there's huge disparities in breast cancer across the board, and we want to try to find ways to understand that better. So as this slide says, breast cancer isn't just one disease. You can get a very, very aggressive disease. You can get some that are quite treatable and people have really great outcomes. And we're still understanding who's going to get what type of disease. It's not always well understood. People don't always know ahead of time. We know that younger women can be at risk for very aggressive disease, and that's very concerning. And we don't have the best ways to screen younger women for cancer. And we also know that for a long time, we thought about family history as being sort of the key driver of who was going to get cancer. And we know that that's not the case necessarily. It really varies. We found so far in the wisdom study, there's half the people in the study are getting genetic testing done. And those people who learn that they might have a variant that could put them at high risk for breast cancer, things like BRCA that we've heard about and other genes, most of them actually don't have a first degree relative. That's a mother or a sister, a daughter who have breast cancer. So they don't have what we consider to be a really concerning family history. So there's a lot we still need to understand about why some people get breast cancer and others don't, why some people get certain types of breast cancer, and some get easier to treat, some get harder to treat cancers, and really looking to understand why breast cancer outcomes are worse in some communities, in some populations, what contributes to that so that we can address it and hopefully change it and have better outcomes for everybody. So that's sort of our driving thing about why we're here, why we're having these conversations. So we have a group of folks from the wisdom team here today. We've always been introducing who else is here in the chat who want to talk about today's topic, which we'll get into a little more, which is breast density. So I said that I'm Jen. Allison Silver-Fiscalini, who runs the Athena Network and the Wisdom Program. I don't know, is Kim Rhodes on? Who, let's see.
I'm here.
Hi. Oh, great.
Hey.
Kim Rhodes, who runs the community engagement office out of the Cancer Center, and Jeff Tice and Elad Ziv, who are two investigators on the wisdom study. They are also researchers. They're also internists and primary care folks who are going to talk to us today and help us understand some of the questions that we all are hearing coming up about breast density and about breast health. So the goal for these sessions, really, this is meant to be a conversation. We have some folks here who can answer questions we have, but we want to hear what your questions are, what you know, what we should know from you. So obviously, feel free to use the chat to give us questions. Feel free to raise your hand, both in the waving your arms sense and the little hand raise feature in Zoom, or just chime in if you have a question, point of clarification, something you know that you want to add. That's what we're hoping, that we can make this less of a presentation, more of a conversation. And we are recording this so that we can share it so folks who aren't able to attend can get this knowledge as well. And then later in the meeting, we're going to have a Zoom survey is going to pop up with some ideas that we've been hearing about, topics folks might want for these forums. And obviously we want to hear which ones of those are appealing to you, or which other topics you want to hear about, which you can also go ahead and put in the chat at any time as well. And we'll keep track of them so that we make sure we are covering topics that are interesting and useful to folks. So over the last couple months, the forums we've had, we started by thinking specifically about the impact, impact of breast cancer for folks who are Black or African American. As we've described, we know there's huge health disparities. For a long time, the case has been that Black women are diagnosed with breast cancer at similar rates or even lower rates than white women, but have worse outcomes. And there was a proposal to start screening Black women earlier. So we discussed some of the latest literature, the knowledge about this, who's at risk, what we can do better. Those are themes we want to keep exploring. But something we were hearing this month that we wanted to talk more in depth was about breast density and breast health. So what can learning your breast density, what does it mean? What is breast density? What does it tell us about our risk for disease? How do you know your breast density? What do you do with that information? And thinking about what the wisdom study is trying to learn and understand about that as well. So that's sort of our big umbrella topic for today. So I think we are going to have Jeff Tice jump in at some point, or am I going through? I can go through the slide too, to talk about some of these topics. But just so everyone knows, there's many, many things that lead to breast cancer. As this slide shows, we have some things are explained. We can sort of point to a reason this is why, or a contributing factor to someone getting breast cancer. So things like genetic mutation, like family history. We know that age plays a role. This is race, ethnicity. I would really say, ancestry plays a role, and we know that racism plays a role. There's things we know about certain things we consume or certain things we're exposed to, but there's a lot of breast cancer that isn't explained. It's hard in many cases for an individual person to say, this is why you got breast cancer. We don't always know the answer to that, but we're always trying to learn more. And I think the big piece we want to talk about today again is breast density and that information.
So Jen, do you want me to take over?
Yeah, I was going to say, please jump in. Sorry, I'm like spotlit. I can't see other people.
Okay.
please jump in.
Great. Thanks for setting things up, Jen, and for the introduction earlier. So again, I'm Jeff Tice. I'm a faculty member in Department of Medicine here at UCSF, and primarily work as a primary care physician, but a lot of my research has been in breast cancer risk assessment and prevention, and I'm involved with the Wisdom trial as a co-investigator. So breast density, what is it? We'll show pictures in a minute, and that I think will help more than anything else. It's tissue that absorbs X-rays, and the kind of tissue in the breast that absorbs X-rays as the sort of fibrous tissue and the glands that make milk, whereas fat in the breast doesn't absorb much X-rays. The X-rays pass right through, and those show up as darker tissue or a darker part of the breast, and I'll show that in a little bit more. Interestingly, we talk about density, but it has nothing to do with the texture of the breast or the size of the breast. You can't feel density the way we're talking about it. We're talking about density on a mammogram. Clearly, when you examine your breast, you feel areas that are denser than others. Those don't necessarily correspond to areas that are dense on the mammogram. Consistently for at least 3 decades, we've known that women with more dense breast tissue on their mammogram are at higher risk for breast cancer compared to women with less dense tissue. But the real reason we even know about that is because radiologists wanted to alert clinicians and themselves that if there's a lot of density, it makes it hard to see a cancer. And I'll talk about that a little bit more on some images. So, I mean, this is essentially the reason cancers or precancerous lesions show up as white on mammograms. So they're dense, they absorb X-rays, and the dense tissue also appears white. So if you have dense tissue and you have a cancer and they overlap, you may not be able to see the cancer. So radiologists have known for a long time that if there's a lot of density, their reading of the mammograms is not as accurate as when there's very little density, when the breasts are mostly fatty. So here is what the images look like. They're categorized now from A, B, C, and D. They used to be 1, 2, 3, 4, but the names have stayed the same. So the upper left image is breasts that are almost entirely fatty tissue. Clearly, there's some absorption of the X-ray. You see outside the outline of the breast, everything's black. So there's no absorption. So we do get some absorption of X-rays, and the skin absorbs a fair amount. That's why it's fairly bright along the contour of the breast. But this is a breast without much density, so it's easier for the radiologist to pick up a cancer if one develops. And as we move to the right, you get to category B, which is scattered areas of density, category C, heterogeneously dense, and then finally out to the right, category D, extremely dense. And you can see there's lots and lots of white areas in the breast. And so you can imagine a small cancer, which is also shows up as white, may be missed in a mammogram like this. What else was I going to say? Yeah, go ahead. So there are some things that we see consistently. As women get older, the density goes down, and there is something that's particularly happens through the menopause. When estrogen levels go down after the menopause, there's a more rapid decline of breast density, and then it flattens out again. So clearly hormones play a role in breast density, but there are many other factors. And just because you have a dense breast doesn't mean that you're at very high risk for breast cancer, despite what some of the notifications suggest. Half of women have dense breasts. This is normal. And so you shouldn't get too worried about it. You know, Allison, can we go back one slide? I wanted to highlight one more thing, if it's possible to go back. If not, that's okay. All right. Thank you. Perfect. So what we don't have on this slide is how common it is to have these 4 different categories. So category A, it's a little less than 1 in 10 women, a little less than 10%. Category D, the extremely dense, this is the higher risk, also a little less than 10% for most women. So these are the minority. Actually, having category A is really good. You're at a particularly low risk for breast cancer. Again, partly because it's easy to pick it up, but more importantly, there's something about density that's associated with risk. And the other 2 categories are the most common categories. About 40% of women fall into category B and 40% in category C. Yeah, I just wanted to give some sense of how common the individual categories are. Go ahead forward again. Thanks, Allison. You know, one thing, even in women with mostly fatty breasts, sometimes the radiologists miss something. The cancer doesn't show up. So no matter what your density, if you notice a change in your breast, if you feel a new lump that's concerning, if you see dimpling of the breast that wasn't there before, definitely alert your primary care physician, your gynecologist, whoever is taking care of your breast health. You know, we definitely can still develop breast cancer. Women can develop breast cancer even after a normal mammogram. And in fact, the breast density legislation, which we'll get to maybe on the next slide, really was spearheaded by a woman who had a normal mammogram and then a few months later was diagnosed with an advanced stage breast cancer. So she was quite frustrated by the fact that she had dense breasts. Nobody told her that meant that the mammograms may not be as accurate at picking up an early breast cancer. Next slide, please.
And Jeff, can I interrupt with a question that's related to that? That's in the chat.
Yeah, absolutely.
Yeah, so there's a question Elizabeth is asking about your risk being higher because you have dense breasts versus it's harder to see and diagnose because of dense breasts. Can you think, what's the relationship between those? Is it both? Is it one or the other?
It's both. So, I mean, it's hopefully from the images, you can see how challenging it might be for a radiologist to find a small breast cancer in a breast that has a lot of mammographic breast density. And so in part because of that, there is an excess of early cancers that show up because it was missed on the mammogram. So there is sort of that a little bit of the what we call masking. You miss a cancer that's there because of the dense areas mask or hide the cancer, and so then a woman feels a lump or something else happens, and you find a breast cancer, and that's less likely to happen in women with less dense breasts. And so I think your instinct is correct. Some of the risk associated with breast density is due to these missed cancers. But we've looked, if we ignore all cancers diagnosed in the 5 years after a particular mammogram and look over the next 5 to 10 years, there's still a substantial increase in risk as breast density gets higher and higher. So the masking doesn't explain all of the association between breast density and risk for future breast cancers. Part of it is the masking, but most of it actually is just that it reflects something in the biology of the breast that puts women at higher risk for breast cancer. And that is still not well understood and is an area of active investigation at UCSF and many other institutions. So happy to expand on that, or if you wanted to say anything more about your question, if I didn't answer it fully. All right.
Thank you. That was great.
Okay, great.
Yeah. And there's one other question, Jeff, from Gloria asking about, are there any other molecular diagnostic or other biomarker tests that can detect risk sooner for everyone? Is there anything, you mentioned something about, looking at the tissues and things like that?
Yeah, I mean, interesting. So there aren't many good biomarkers other than things that we're studying in the wisdom trial. I mean, certainly the genetics are important. In wisdom trial, we put together breast density, family history, age, and the genetics. So the single nucleotide polymorphisms, or SNPs, the one letter changes in the genome that are associated with small increases or decreases in risk. But when we put together 100 or more of them, they are helpful in, again, sorting out who's at higher risk and who's at lower risk. There are some things that we haven't included. There are a couple of blood tests that make some difference in premenopausal women. Insulin-like growth factor 1, IGF-1, is associated with premenopausal breast cancer, and hormone levels, particularly estrogens in postmenopausal women, are associated with future breast cancer. But there are very modest increases or decreases in risk, and I don't add substantially to what we learn from a woman's age, her family history, and the things that we're doing in the wisdom trial. But clearly an active area of research, and really related to that, there's just an article out today in the Annals of Internal Medicine highlighting a new estimate for how many breast cancers that are diagnosed with mammography represent overdiagnosis. So a cancer that they find, but that was never going to cause symptoms in a woman's life. It wasn't going to affect her lifespan. One of the areas of active research, Dr. Esserman here, it's one of her core passions, is to try and look at those cancers and say, this is an indolent cancer and is unlikely to spread, cause significant illness, so we can avoid aggressive surgery, avoid chemotherapy. We're moving in that direction. There are some tools we use, but we still need a lot more and better tools to really identify those cancers. So that's a biomarker. Once you have a cancer, we're also trying to find better biomarkers of risk. Certainly there are things that people are very excited about, things called liquid biopsies, where you take a blood test and you look for DNA that that comes from a breast cancer, and there's evidence that these cancers shed DNA into the bloodstream, and we can pick it up before we can pick it up with a physical exam or a mammogram. But that's certainly it's not FDA approved yet. People are excited about it, but it's unclear how useful that will be. So that's one other tool that is certainly under investigation and may be useful in the future. Sorry, I want to go to next slide. Try and keep the chat open. So please alert me if there are things in the chat or if there's a hand up. It's hard to see. All right. All right, good. So this is, as I said, there was a woman in Connecticut who was diagnosed with breast cancer soon after a normal mammogram. And she had very dense breasts, and she's been, she was a strong advocate for alerting women to the presence of density if it was there. And a number of states, including California, passed laws saying that women must be notified if they have dense breasts, and that's the top two categories, either C or D. And the letter about their mammogram should tell them both that it may hide or mask a breast cancer, and also that it is associated with a higher risk of breast cancer over the next 10, 15 years at least. And so this is the language, I think, from California. I don't think it's passed yet. There is a law, a federal law that's being considered, and there may be more standardization across the entire country over time. Next slide, please. So what can you do next? I mean, one of the important things, and this is why we're doing the wisdom trial, is no single factor is useful on its own. Even for BRCA carriers, the SNPs are important modifiers of risk. The single letter changes in the genome. Some women have extra risk from their SNPs, and those women with a BRCA mutation are at much higher risk of developing a breast cancer. And those with a lot of SNPs that lower their risk are at lower risk. And age is an important risk factor. Most women who are BRCA carriers don't develop breast cancer in their 20s, and that's why we don't usually recommend any screening before about age 25 or 30, depending on which guideline you look at. So it's important to put all of the risk factors together when assessing your individual risk. We're trying to help to provide tools and educate physicians as well as patients about that, and certainly women at the highest risk, we recommend more frequent screening and adding an MRI. The MRI, there was one trial out of the Netherlands looking specifically at MRI in dense breasts. With MRI, you can often detect cancers in women who have cancers that are missed because of a substantial amount of breast density on traditional mammograms. And as the slide says, join Wisdom, help us learn more about this, help us evaluate new risk factors. I mean, we are constantly, this is a learning tool. When we get better information, a better risk assessment tool, we learn more about the genetics. We're adding that on a regular basis, updating our risk models and our assessment of risk factors moving forward. So Wisdom is a great learning platform to help advance this field. Next slide. Is there anything else, Allison? No, good. Hopefully now we have a little over half an hour, plenty of time for questions and discussion. I'd love to open it up to everybody.
Does anyone have any questions either about risk factors or breast density or what the information means? I see someone noted that they did get a letter last week that noted that they had dense breasts. It's something you are hearing more and more about in the news and with different information about breast cancer. So if you have other questions, please feel free to raise your hand or put something in the chat, and we will go through some of the more logistics around the wisdom study after giving people a chance to ask more questions.
Allison, can we close the slides during the discussion so we can see each other a little more easily?
There we go.
Great, thanks, Allison.
Yeah.
Yeah, I mean, for people that we, so I'm involved with another national study called the Breast Cancer Surveillance Consortium, and we collect information from women when they're getting their normal screening mammograms at sites all around the country. And we've developed risk assessment tools using that information. And the Wisdom trial is using one of those tools, the Breast Cancer Surveillance Consortium BCSC model, right? And that's freely available on the web. Women can go explore. You can put in your age and your own risk factors, and it does compute things for you, give you information. It's really intended to help communication between patients and their clinicians, but it's freely available on the web, and also there's an iPhone app and I believe an Android app. If not, then our updated version, which there's going to be a new version in a few months, will also be available on Android phones as well. There, Jen put the link in, and yeah, I know we update that. That's a part of the website. It has a lot of detailed information for people who want to drill down about each of the risk factors and so on, and how that contributes to an individual woman's risk.
I'll ask a question that I hear often, or that I don't know the answer to while other folks are thinking. Actually, maybe I'm going to ask two questions that are related. So one is, is there a difference? I think people talk about having fibrous breasts and having dense breasts. Are those the same? Are those different? Are there more than one thing? Or lumpy breasts? Are those the same or different? I don't know which are clinical terms. And then I think related is how do self-breast exams or clinical breast exams factor into this conversation?
Yeah, a complicated question. I mean, I heard multiple questions. The first one, yeah, the sort of fibrocystic disease or the lumpy breast that women feel and that clinicians feel when they do a clinical breast exam, do not correlate well with breast density. So they're really separate phenomenon. So just because you feel a lot of things in the breast, I love your cat, doesn't mean that you necessarily have dense breasts. I'm sorry, the next part of your question.
It was on self-exams, and I think somebody else actually asked us as well about the different changes in recommendation for doing exams.
I mean, we now preach breast awareness rather than self-breast exam. They're the only large studies where we randomized women to teaching about self-breast exam and doing them. So half of women were randomized to actually do that, and half were not, and were followed over time for development of breast cancer and eventually death from breast cancer, or a metastatic breast cancer, and so on, the more high-risk breast cancers. And we saw no difference in outcomes over 5 to 10 years in women who were taught how to do self-breast exams and encouraged to do that monthly versus those who were not. We know they were doing them because actually they came in and had biopsies at a 50% higher rate. So if a group of 100 women, 4 of them would normally end up having a biopsy. If they were in the self-breast exam arm, they actually came in 6 times for biopsies. And so you had an increase in biopsies, no benefit in terms of reducing death from breast cancer. And so most guidelines drop self-breast exam from routine recommendations because that suggested net harm. You got these unnecessary biopsies. It really didn't impact long-term outcomes. The studies, there is some controversy because they were not done in the United States. I'm blanking where the 2 different studies were, but there's some concerns of they're management of breast cancer isn't as good as here in the US, so maybe the results don't apply. So there's still some back and forth, but certainly there was not even a hint of benefit to do it. And many women that I've interacted with often felt guilty if they missed their self-breast exam, or if they weren't doing it right, or it just made them anxious. So, we've moved away from that, but I think it's really important, as we highlighted early on, that if a woman notices something while, bathing, that's a change, that you should still bring that to your healthcare provider's attention, because a good proportion of breast cancers are detected by women in between mammograms, and we don't want to discourage women and thus lead to potential delays in diagnosis. Clinical breast exam, controversial also. I mean, there was a big Canadian study that suggested that clinical breast exams were as good as routine mammography, but they had clinicians that got extensive teaching, did like a 15-minute systematic breast exam, better than most clinicians do. And there was no added benefit to clinical breast exam on top of mammography. So it's also become less of a strong recommendation, though certainly in higher risk women and BRCA carriers and so on, the recommendation generally is still to have at least one. Often it's recommended that there's a clinical breast exam twice a year.
No, but it sounds like for most women, it's not strange if your doctor's not doing it or just having you do mammogram.
No, I think we've moved away from that, as long as women are getting a routine mammography. Again, if in lower resource settings, in places that don't have access to mammography, doing a really careful breast exam would pick up almost as many breast cancers. I mean, or at least in the Canadian trial, suggested it was as effective long-term at preventing death from breast cancer.
We have lots of questions coming through. I'm going to try to group some of them together. So there was a question earlier about sort of why the prevalence of breast cancer is so high. Why are so many people getting breast cancer? What can we do about it? And I think related to that is someone asking, does breast size affect whether you get breast cancer? And someone asking about how often cancers are occurring in women who have these genetic variations versus those who don't, which I think most are people who don't have the genetic variations, if I understand. But why is breast cancer so high? Who's getting it? Yeah.
We don't fully understand why. I think, one of the big changes is there's something about our modern lifestyle that leads to an increase in breast cancers. Asia traditionally has had very low risk of breast cancer, but when women from Asia move to Hawaii, their breast cancer incidence goes up a little bit. But then if they move to the continental US, it goes up even more over generations. It's not an individual thing. And we also even saw that in BRCA carriers in Iceland. So Iceland basically stores all of the breast cancers in one institution. They have one, what we call founder mutation, one specific change in BRCA2 that explains almost all of the BRCA mutations in Iceland. It's a relatively small country. I want to say 800,000, about the size of San Francisco in terms of population, bigger in terms of geography. But and they saw from 1920 or 1900 to 1980, I think was when the study was done. Over that 80-year period, there was a 4-fold increase in the incidence of breast cancer in women who carried this BRCA mutation. So it was something about the changing lifestyle that affected breast cancer risk significantly. I mean, again, it went up by a factor of 4. Lifetime risk went from about 20% to about 80% in the BRCA2 carriers with this particular mutation in Iceland. And it probably reflects a whole lot of things: better nutrition leading to women starting to have their menstrual cycle earlier, and so having a longer exposure to cycling estrogens and progesterone, which clearly are associated with the risk for breast cancer. And then women often, as in a more Western culture, they delay childbearing. So women, instead of having kids in their teen years or early 20s, are now more commonly having kids in their 20s and 30s. And we know that there are changes in the breast with the first pregnancy that decrease your risk for breast cancer long term. We've known for a long time that the earlier a woman has their first child, the lower their risk of future breast cancer. So that's probably contributing. We drink more alcohol as a consistent risk factor. So drinking alcohol, again, reflecting our better access to food and the over-marketing of food in our culture, particularly postmenopausal women are heavier, and weight gain or being overweight is a risk factor for breast cancer, particularly postmenopausal breast cancer. Again, probably related to estrogen, because fat cells convert testosterone to estrogen in the breast and elsewhere, and that increases the risk for breast cancer. So many things, small things, probably contribute to this risk, and we're not gonna change most of them. Unfortunately, there have been people really interested in the hormonal hypotheses who've been trying to come up with sort of some pill to mimic pregnancy that young women would take or something, but quite controversial and not something that has gotten any traction outside of sort of academic circles. So hopefully that answered some of the questions about risk. I mean, it's similar to risk for prostate cancer in men. The lifetime risks are fairly similar. They're both quite high. It's an interesting question about breast size. The short answer is no. Most of the studies of breast size didn't show any association between cruder measures like cup size and breast cancer incidence, or more quantitative measures of breast size based on mammograms or other things. On the other hand, we do know that women who have breast reduction surgery do have a lower risk, and it's related to the amount of breast tissue that is removed. So there is something about it, but it probably, the breast size doesn't per se matter because of the distribution of breast tissue that, the glandular tissue that is the kind of tissue that forms that eventually develops into most of the breast cancer. So that's why invasive ductal cancers are the most common. And so those ducts are spread out throughout, and the amount of ductal tissue probably doesn't correlate very well with the volume of the breast. So yeah, one of the questions, are you at higher risk if you've never had children? Yes, that's true. And how often is cancer seen in women who don't have any of the genetic variations? We haven't done those analyses yet. Partly we're waiting till a certain time before we kind of do our primary analyses of the data. So I can't answer that question directly, and it's a little bit hard. I mean, I think the vast majority of women don't have one of the changes in the genes, those 9 genes that we test for. So the hereditary breast cancer, certainly the vast majority don't have those, and because most of the breast cancers are happening outside of that group, I think they're going to be overwhelmed. But if you're talking about the risk from those several hundred single nucleotide polymorphisms, the changes in the single letters of the genome, there we are combining it all. And so we could, we can look at women who have lower than average or higher than average. I'm sure we're going to see more breast cancers in those who have higher than average polygenic risk score. That's the jargon for the risk that we calculate by putting together hundreds of these changes. So sometimes that risk is 1, which means it's average. It's similar to the average woman in the population of the same age and other risk factors. Sometimes it's 2, which means roughly it's a doubling in the risk in women who have that a polygenic risk score of 2, or it can be 0.5, so that lowers your risk by half. And so, I mean, I wouldn't be surprised if a third or more of our breast cancers are in women whose polygenic risk score is less than average and who don't carry one of the mutations in one of the 9 genes that we're taking for those, that we're sequencing, the ones we know are associated with a strong hereditary risk or familial risk for breast cancer. Would I recommend MRI versus tomosynthesis?
Again,
yeah.
Can I actually add, can you add ultrasound into that as well? Like sort of all the different.
Ask 10 radiologists, you'll get 20 answers to this question, and I'm not a radiologist, so very controversial. Tomosynthesis helps a little bit, but some of the in really carefully done studies where radiologists are trained and are very helpful, are very careful about the way they're reading things in terms of reducing mostly false positives in women with dense breasts. But in the real world studies, we actually haven't seen it be as, we've seen almost as many, or in some cases more callbacks with tomosynthesis than in traditional digital mammography. We're not using it very often as a supplemental imaging type in women with dense breasts. In part because it's becoming the standard now. More and more of all mammograms are being done with tomosynthesis. And it doesn't help, helps a little bit, but it doesn't help a lot in finding cancers in dense tissue. Digital mammography itself helped. The real benefit of moving from film to digital was the ability to find cancers more often in young women with dense breasts. So that was a step forward, but tomosynthesis is only a modest addition to that. So in terms of what to use, ultrasound versus MRI, ultrasound definitely finds things, but not the majority of missed breast cancers. And you get a lot of false positives. So you get a lot of, we're worried about this, come in, get a biopsy, and so on with ultrasound. I want to say that, so adding ultrasound to tomosynthesis or digital mammography found a few more cancers, but not a lot more. Adding MRI found a huge amount more. And the combination of standard mammogram plus MRI found every cancer that was found on ultrasound. So most people, if we feel like risk is high enough and the breasts are dense, that MRI is the better approach. At least that's my reading of the literature. Again, some radiologists who are expert at ultrasound still feel that that's a really good option for women as well. In part, it doesn't take as much time. Right now, the kind of MRI we do requires contrast, which means you need an IV, and there's always risk with an IV and also giving contrast. And it takes a lot of time and it's expensive. So there are downsides. So there's controversy in this area. There's not consistent guidance, but the highest risk women, for instance, BRCA carriers, we always recommend MRI. We don't recommend ultrasound, and we don't recommend adding ultrasound to MRI plus mammography because the data are clear. Ultrasound finds no additional cancers in that setting.
I think the only other question that was on there was about AI and mammography. And then I think we might switch back over and I'll tell the group a little bit more about the wisdom study and then we'll wrap up.
I had just one more question that came through just to me, which was about breast enhancement and if that's linked, which is I think a short answer.
So meaning by breast enhancement and not background parenchymal enhancement, you mean?
Sorry, I assume a breast augmentation. Yeah.
Okay, so so inserts and things like that. No strong association with breast cancer, either increased or decreased risk, other than if a woman has a significant amount of breast tissue removed and then an implant put in. The implants do make it a little harder to read the mammograms, and I think that's one area where tomosynthesis may be helpful. I actually, not being a radiologist, I'm not sure what the latest thinking is about the most accurate approach to screening with when a woman has had augmentation. But I know they're extra careful because again, the inserts sometimes make it a little harder to see things. AI, that's the hot topic. There are two different areas. One is just for diagnosis to help the radiologist find areas that might be cancer. And the other, which I'm more familiar with, is using AI as a risk assessment tool. And the older forms of AI to help identify areas on a mammogram that might be breast cancer have not been shown to be very useful. But that was sort of the old style AI, and the new neural network approach is much more sophisticated, but much more of a black box, and is an area of active investigation and may be useful. And it's the sort of thing where we're actually able to mimic the human's ability to do pattern recognition, even if it's not conscious, and often improve upon it. So definitely an area of active research for diagnosing a breast cancer. There are 3 or 4 different AI approaches that have been shown to be better than our typical risk models, and at least their initial assessments of, can they predict future breast cancers? We've put in grants to look at that, both the BCSC and the Wisdom trial, hoping to develop Wisdom 2.0, where we hope to integrate and investigate the value of AI. So certainly a very promising area for both diagnosis and risk assessment. Not quite ready for prime time, but everybody is studying it now.
Well, thank you everyone for your questions. And I'm going to start sharing the screen one more time just to give a little bit of an overview, a little more overview about the Wisdom study. I know it's come up a couple of times in conversation. Some of you may be more familiar than others in terms of what Wisdom is. Hopefully you can see my screen. Yes. Okay. So I think, as we've discussed, we know breast cancer is not one disease. Everyone's risk may be different. You may be at risk for developing more aggressive cancer versus less aggressive cancer. Again, in our mission to try and understand how we can screen women more effectively, how we can make sure outcomes are better, we are always trying to ask questions and try and understand these risk factors as best to our ability, and to continue to learn and to grow. And that's what the Wisdom study is all about. We really want to integrate risk assessment into screening, not just have screening. Everyone starts, at the age of 40 and is screened every year, where really the only information being used to tell you when you should screen is your age. We're trying to take all of these risk factors that we know about to learn whether doing a comprehensive risk assessment and then having that drive your recommendations for screening is as safe and effective as a one-size-fits-all approach. So that's really what we are doing here in the Wisdom study. It's a modern era trial where we are trying to understand who is at risk for what type of cancer, and really challenge that notion that everyone should be screened the same. So how does it work? How do you participate? So the Wisdom study is actually open to all women nationwide who are between the ages of 40 and 74, who have never had a diagnosis of breast cancer or ductal carcinoma in situ, or DCIS. So women who are being screened for breast cancer who have never had it. You don't need to go and be seen at any particular medical center. You can register online at our website, www.thewisdomstudy.org. You can do it on your mobile phone, on a tablet, on a computer. You fill out a registration form, set up an account, and you'll go through the enrollment process from there. So what we're testing is a standard annual screening, our standard of care that everyone is used to hearing about. Everyone should start screening at the age of 40, compared to a more personalized approach, as I mentioned. And one of the novel pieces about that personalized approach is that we offer a genetic test to everyone in the personalized screening arm of the study. It's an at-home saliva-based kit. We mail it directly to your house. You spit in a tube, you mail it back. We get the results back from the lab and put it all together with all these risk factors we've been talking about today. Your breast density, your family history, your prior breast biopsies, your age, other factors, and we recommend a screening frequency that matches your level of risk. So for some women, that may mean coming back every 6 months with an MRI. For other women, and the majority of women, it may be that you can come back less frequently, but really trying to create a more personalized recommendation for everyone. And in the end, we'll compare. Is it as safe and effective as telling everyone to come back every year, starting at the age of 40? Is one better than the other at finding cancers and reducing the number of false positives, those false alarms that you sometimes get after a mammogram? And every year we'll ask you to come back and complete a questionnaire. Risk can change over time. You may, simply aging, or maybe a new family member got diagnosed, or maybe you've had another biopsy. That we will gather that every year and update your screening recommendations so that you on a yearly basis have a new recommendation based on your most recent risk profile. If you are at high risk, we have breast health specialists who are trained in breast cancer, also in genetics, to help counsel you and give you the information back. And we have decision support tools that we offer as part of the study as well. We give you your screening assignments with an explanation. We give you your genetic testing results back. And we encourage you to take those to your physician, to your provider, and to have a conversation with them to inform them that you're part of the study. This is the information that you received from the study, and have a dialogue with your provider about the screening recommendation that might be right for you. So that's, in a nutshell, the Wisdom study. Again, it's a huge study. We are trying to enroll over 70,000 women. We're about halfway there. So we have a little ways to go. And so we are always looking for new ways to bring awareness to the community, to make sure everyone is aware of the study and is offered a chance to participate. There's no cost. All of the genetic testing and the risk assessment is all provided to you at no cost. However, the screening that we recommend, the mammograms, the MRIs, that is all part of standard of care. So you would still get your mammograms from your local provider. They would still order them for you. And you would just let us know when you had your mammograms, and we would get the results so we can try and incorporate those back into your updated screening recommendations. Let's see. So I have got the URLs for the Wisdom study, the website. We encourage you to join, to continue to come to these community forums. This is a space for all of us to learn and to have a dialogue, to understand, what matters most to the community, what topics would be of best interest. What questions are you hearing your friends or your colleagues talking about? We want to have a dialogue and to understand what matters most. But also where there might be areas that we can continue to discuss and build each other's wisdom on the topic of breast health and breast screening. You can see our social media here too, so I encourage you to follow us and continue to be part of these discussions. And I will pause there. I'm just looking at some questions that have come in. But please send questions in the chat. Also in the chat, you'll see a link to an evaluation survey. We would love for you to fill that out. We also have a quick poll that we'll launch in just a minute asking what topic you may want to hear about, or your top choices of topics you may want to hear about on the next forums. Actually, Marcella, while I am reading some of these questions, maybe you can launch the poll and we will do both at the same time since we're coming up on the hour.
Sounds good.
Okay, so let's see. I have a message here. Are there recommendations for some to come less frequently than once a year? How do recommendations factor in the lack of data on Latinos and African heritage women? That's a great question. There are recommendations that say to come back less frequently than once a year. And I can have Jeff speak to some of the rest of that question, though we do part of the BCSC risk model that he was talking about factors in self-reported race and ethnicity, and also some of the genetic information that we analyze has some specific single nucleotide polymorphisms or SNPs that are specific to different races and ethnicities. It's not perfect by any means, but this is exactly why we are trying to continue to learn and to make this study as representative as possible so that we can continue to contribute to that literature and contribute to the scientific knowledge to improve our ability to predict risk in different communities. And Jeff, I don't know if you want to add to that at all.
I mean, I guess, you know, we mostly are following. I mean, part of the motivation for this is that there are conflicting recommendations, but many recommendations in the US say every 2 years after a certain age. And so, others say between the ages of 40 and 50 or 40 and 55. Yeah, it really depends on a woman's risk, and we're kind of putting some information out there and guiding recommendations that sort of match the risk that underlies women who are recommended for screening every year or every 2 years. Yeah. I saw some interesting questions. There was a question about breast tissue in African-American women. Certainly at UCSF, we have to get authorization from women, but we always want to capture any biopsy tissue and use it for research if a woman wants to make it available. And as we're collaborating with an African and Nigerian investigator at the University of Chicago who's sort of spearheading a lot of the cutting edge work in the genetics of breast cancer in women of African descent. And so, yes, we would love to, be able to get the okay from people to use their tissue, but we always have to get specific consent for something like that.
I'll note too that, you know, one of the next phases of the Wisdom study, Wisdom 2.0, is for women who do develop breast cancer while on the study, that we plan to request access to those tissues so that we can do molecular testing on those tissues and be able to then look back and say, what were the risk factors prior to that diagnosis? Is there something that we, you know, should refine so we can assess people more accurately to start off with? So yeah, the Wisdom team has lots of wonderful ideas. We're going after as much funding as we can to be able to ask these questions and really be able to build upon the knowledge and the information that we're gathering in this initial phase of the study, so we can continue to build in AI, build in the molecular profiling and diagnostics and other things that are coming to the forefront, and we continue to evolve and learn. Right, so let's see, thanks. I see the poll is open. If you have any last suggestions, please send them through, but I think we've got some good responses here, and we are doing these forums every month. So, you know, we will find our resident experts who can speak to the various topics and respond to the interest that you've put forward in terms of these different topics. We want to make these as informative and engaging as possible and continue this dialogue on a monthly basis. So our next forum is on March 28th, so 1 month from today. These will be the last Monday of every month at 4 o'clock Pacific time. I believe since you've registered, we're now registered for all of them moving forward. We encourage you to continue to attend and be part of the discussion, but also to try and see if there are others that you can invite to join these conversations, or even to check out the Wisdom Study website or to ask questions. We are looking to make sure that we continue to grow and we continue to expand and hear from more of you and engage a wider audience here in these forums. Jen, anything more? I know we're a little over time.
No, thank you all so much. It's been wonderful. And yes, please make sure you share your ideas on what you want us to discuss next. And we're looking forward to seeing you next month. Lots of interest. So, oh, great. Thanks for the full result.
Yeah, thanks for all the great questions. So, yeah.
All right.
Thank you so much, Jeff.
So much. Take care, and please do fill out that evaluation. Let us know if you have any questions, and we will make sure that we incorporate those into our next forums. All right. Take care, everyone.